Dr. Ping, you want to comment on the
I want to comment on that picture, if you allow me.
Yes.
Well, this is something extremely important for the audience. In distal colostograms, in MRI, in all the studies, we must keep in mind the following. See, this is the coccyx, and do you see something here running like this? All that is muscle, voluntary muscle. So this, according to this image, a non-experienced radiologist will tell you that the rectum is very high, that the vagina is extremely high, and that the common channel is many centimeters. That's not true. What the radiologist doesn't know is that this area here is compressed by the sphincter mechanism. And that is also related with the so-called long rectovestibular fistulas. We have never seen a long rectovestibular fistula. That's the old idea that comes from the time of 1953 from Dr. Stephens. So you can, if you don't put hydrostatic pressure, this never opens. I don't know if the rectum is here or here or here or here. But I do know that from the pubococcygeal line down, all this is muscle. And unless you put hydrostatic pressure, you will never know the real location of the rectum. Keep that in mind. No hydrostatic pressure, then learn to make this diagnosis, anatomic diagnosis. In this case, according to this, the rectum is very high, the vagina is there, and the common channel is very long. That's false. Unless you have a distal colostogram and an endoscopic study, you cannot say that. And the same in the male patient, when you just put contrast material by gravity in the distal colostogram, the contrast material always stops in the PC line, always. And the radiologist will tell you that the patient has a high malformation. First of all, we don't do that classification. High, intermediate, and low is useless. We go by specific defect with specific characteristics, because what you want to know is how are you going to operate, what approach are we going to use, what's the final prognosis of the patient.
Thank you, Dr. Pini. Actually,
I need more information. But let me tell you something more important than anything in this study. Number one, this patient has a sigmoid colostomy and a very short piece of rectum. You cannot take this rectum down here because it's anchored to the abdominal wall. That's really important. You go there, you open, you cannot bring the rectum down, then you are in trouble. And you have to, we discuss that in our course. The same here happens. This patient has a sigmoid colostomy, very short piece of bowel. You cannot bring that all the way down here. And the same here, somebody's opening sigmoid colostomy, and what say, that's why we say, do not open sigmoid colostomy. We will use descending colostomy. They can look for the sigmoid or the pull through. So that's really important in this study. And then the interpretation of this, as I told you before, this doesn't mean much because it could be muscle compression. We need an endoscopy to see the real anatomy. And the same with this. So these studies are useless. Here, what we see is double vagina. Apparently it's a double vagina. But we need the endoscopy to know exactly what are we going to find during the operation. And we don't separate anorectal malformation and urogenital sinus. We'll repair everything at the same time.
Yes, that's confirmation that no single investigation will be enough in cases of cloacal. We need to complement both endoscopy and contrast studies and maybe cross-sectional imaging, which will only help in planning, as the title of the panel, planning before pre-op going to reconstruction and to decrease the probability of surprises, intraoperative surprises, which are almost, we agree that it will be with a long channel colorecus.
First of all, if the radiologist sends me an X-ray like this, I send the X-ray back. That's not well taken. First thing, when you take a baby to the X-ray department, first you ask the radiologist to take an AP film. You want to see the entire pelvis, to see the sacrum. Then you turn the patient lateral in the perfect lateral position. Is this perfect lateral? Absolutely not. See, the perfect lateral, you want to see an anal marker in the anal depot, and to be able to see the sacrum complete in both hips overimposed, one in front of the other, to know that it's perfectly oblique. X-ray will give you a false image. So then you want to know, in 8P position, you inject contrast material in the mucosa of the mucous fistula, the colostomy. You want to know how much power you have from the stomach to the end, to see if you have enough length. And then after that, you turn the patient lateral and continue the injection, but always looking at the sacrum, at the coccyx, and the position of the rectum. This is useless. And then in this X-ray, the same thing. This is an AP film, and the rectum is here, but we don't know where is this in the pelvis. We don't know if this is above the coccyx or below the coccyx, or where is that. And then there is this structure and this that I don't know what it is. So in summary, you will see a patient with a cloaca. You need a good idea of the perineum. It's flat, it has a midline groove, it has a good sphincter, and then you need a colostogram, distal colostogram, to know how much power you have. And then you go from below and you cannot do a good distal colostogram in cloacas because the contrast study escaped from below. In unrectal malformations in males, you can put hydrostatic pressure and distend the rectum and see exactly what it is. In cloacas or vestibular fistulas or vaginal fistulas, there is no way to generate enough pressure to distend the rectum and overcome the muscle tone of the sphincter. So you always find this kind of narrow structure, but you don't know if that's like this. You don't know if that's the effect of the muscle, but perhaps this could be distensible more here. So the technique, send your radiologist to us, and we will train your radiologist so you can have a direct communication, you have a proper diagnosis. What you want to know at the end of is the length of the common channel. Radiologically, you cannot know the length of the common. You need an endoscopy, and then you want to know how much rectum you have, and with the endoscopy, you complete your study in your head and plan the operation.
Thank you, Dr. Pena. Yes, of course, we need to see all the study of the